Executive Director of Include NYC, one of the partner organization in New York State Transition Partners, which is a collaboration of Include NYC, Starbridge in Rochester, and the parent network of Western New York in Buffalo. I want to just tell you quickly a little bit about our project. We have a website where you can find a lot of resources, both in English and Spanish, for families and professionals who have a young person with a disability in the transition age. That website is www.newyorkstatetransitionpartners.org. And as you can look at videos and tip sheets that would be helpful to you. I also want to bring your attention to an opportunity we have right now for, we are offering mini grants to local partner initiatives throughout the state. So if you're a professional and are interested in applying for a grant of about $5,700 for a project for your organization, I very much encourage you to go to our website and look under the Opportunities tab to learn more about this. If you're a parent and work with an organization that you think could benefit from these funds, please do let them know about this resource. Finally, if you don't already get our Access newsletter, you can go to the website to subscribe. We send that out monthly with current resources and events throughout New York State for families that have a young person in the transition age. So I'm really pleased to welcome the Hillside Health Homes, and I'm going to turn it over to my colleague, Jenny Hutkowski from Starbridge, to introduce our speakers today.
Hi, everyone. This is Jenny Hutkowski. I'm from Starbridge here in Rochester, and I have 3 folks here from Hillside Health Homes. I want to tell you a little bit about how we'll handle questions today first before we get started. We would like you to put your questions in the chat box to all, and then we will try to monitor it throughout, but for the most part, I think we'll be saving questions till the end because it's very likely that some of them will get answered as we go through and hear more about health homes and how they work in New York State. So I am going to introduce the following to you who have a combined 50-plus years experience working in this field, and it is from Hillside, Kevin Cathy, Lynn Higgins, and Phil Balta. And they Phil works with the adult programs, Lynn works with the children's health homes, and Kevin oversees the whole cohesive health homes program. And they will be describing how, with soup to nuts, how the health homes work. So without further ado, here's Kevin Cathy.
Good morning, everyone. If you can proceed to the next slide, please. So thank you for the introduction. Thank you, everyone, for joining us today. I'm going to, the slideshow will discuss what is a health home, Hillside Health Home Care Management as a care management agency for providing health home care management. The eligibility, Lynn will talk a little bit about the eligibility, and then I'll come back and talk a little bit about the referral process, how you would refer an individual. Phil will complete the core services, and then we'll have time for questions. So next slide, please. So what is a health home? Health homes care management are services that ensure everyone has in the individual's care is working together around sharing information that is important to supporting a person's wellness and recovery. Health homes from the beginning was kind of confusing to everyone because of the name. People assumed it had some sort of residential facility or some sort of a home. It's really a care coordination or a care management process where a care manager works with the individuals to kind of coordinate the medical, mental health, substance abuse, and social services needs of the individual. At the bottom of this slide, you'll see a link. If you could click on that link for a second, please. this brings up a video, and I wanted to start out with this. This is actually Hillside Children's Center. If you go to the Hillside website, you can find information pertaining to health homes care management across New York State. If you can click on this, this is a little bit of a testimonial from an adult recipient of health homes care management. I think it does a nice job of kind of explaining it. So we could just take a moment to listen to this testimonial.
Nancy, are you getting audio? Because we are not.
I do. I'm not sure how to stop that or start that up. Would you like me to stop it?
Yeah, because it's not playing audio on our end.
Okay.
To proceed to the slideshow. So essentially, and that link will be left with the slide. It just provides a description where the recipient as well as the care manager kind of describes what it looks like for individuals receiving care management. But again, it's a care coordination service providing care management services to the individual to meet all of their complex mental health and substance abuse and social services needs. You can go to the next slide. So health homes outcomes to all populations, what it was designed for, it came out of the Affordable Care Act. It was really around improving health care and access to health services for individuals. Ultimately, to reduce Medicaid costs by preventing unnecessary hospitalization. So certainly there are times when an individual needs a hospital, and the purpose of this is really connecting individuals to receive their services, getting them connected to primary care support specialists, and really practicing preventative medicine versus trying to address it through acute hospitalization. So you can go to the next slide, please. And this is just to illustrate, oftentimes individuals with complex needs have a lot of providers, and oftentimes they operate in silos because of the demands of their responsibilities. And it leaves individuals confused and not sure where to go, so they take that path of least resistance and go to the hospital. What we're trying to do is address this through care coordination around coordinating those different specialists and providers so that they're all on the same page with regard to the needs of the individual and the one plan of care for each individual. Next slide, please. So Lynn's going to talk a little bit about health home eligibility criteria.
Okay, this is just a basic overview of what qualifies you for health homes. It's important to remember that health home eligibility is chronic condition-based, and that children or adults must have 2 of these chronic conditions as identified by the Department of Health in order to qualify, although there may be one single qualifying condition that we will discuss in the next few slides. And also, children and adults must be appropriate for the health home. They must need a higher level intensive care management and show that they need this service. So we're first going to talk about that each individual must be enrolled in Medicaid. Sorry, next slide, please. Thank you. Okay, So in order to qualify, the person must be enrolled in Medicaid and have the 2 more chronic conditions, as we mentioned, or 1 single qualifying condition. These look a little different for adults and for children. One of the qualifying conditions is HIV/AIDS, and then a serious mental illness for adults or a serious emotional disturbance for the children's model. Also falling under the children's model is 1 single qualifying condition of complex trauma. Some of the chronic conditions included are, for the 2 qualifying, are alcohol and substance abuse, a mental health condition, cardiovascular disease, a metabolic disease or respiratory disease, also obesity. For a comprehensive list of the chronic conditions, you can visit the DOH Department of Health website, and they are all listed there. So next slide, we're going to talk a little bit about, this is the 1 qualifying condition as it pertains to children, the serious emotional disturbance. This qualifying factor would have to be qualifying DSMV diagnosis and meet the functional limitation as outlined here. We've also added ADHD, but the youth would have had to utilize one of these treatments and services, like inpatient, residential treatment facility, day treatment, community residence, HCBS waiver, targeted case management, and they would also need to meet the functional limitation criteria that we're going to go into detail. And just a note that gender dysphoria has been removed from that list. Next slide, please. Okay, and these would be the mental illness as it pertains to children. The single qualifying diagnoses are listed here: schizophrenia, bipolar related disorders, depressive disorders, anxiety disorders, obsessive compulsive and related disorders, trauma and stressor related disorders, dissociative disorders, somatic symptom and related disorders, feeding and eating disorders, disruptive impulse control and conduct disorders, personality disorders, paraphilic disorders, and ADHD with conditions. Next slide, please. And these are the serious mental illness definition for the 1 qualifying condition as it pertains to adult health homes. Would be schizophrenia spectrum and other psychotic disorders, bipolar and related disorders, depressive disorders, anxiety disorders, obsessive compulsive and related disorders, trauma and stressor related disorders, dissociative disorders, and personality disorders. Next slide, please. Okay, also, in order to meet the definition for severe emotional disturbance as 1 qualifying condition, the youth or adult must have some functional limitations in the past 12 months. These can include the ability to care for oneself, family life relationships with parents or substitute parents, siblings, and other relatives, and disruption in their family life, disruptions in social relationships, and deficits in self-control, self-direction, and deficits present in their ability to learn. Okay, next slide, please. Also, in order to qualify for health home care management services, individuals must meet this appropriateness criteria outlined here below. At least one, they have to be at risk for at least one of these events, at risk for an adverse event, or they could have inadequate social family housing support, or serious disruptions in family relationships, has inadequate connectivity with the healthcare system. They might not adhere to treatments or have difficulty managing medications. Perhaps they've been recently released from incarceration, placement, detention, or psychiatric hospitalization. Or they could have deficits in activities of just daily living, learning, or cognition issues. And also, they could be concurrently eligible and enrolled along with their child or caregiver in a health home. So oftentimes, there may be a parent that's enrolled in adult health homes and a child enrolled as well. So the individual doesn't have to have all of this, meet all of this criteria, but they do have to have a combination of one or more in order to be eligible for the program. And I'm going to give it back to Kevin. He's going to discuss a little bit more about the referral process and how to obtain care management services.
Okay, thank you, Lynn. So to talk about the referral process, I'm going to go into a little of the ways in which an individual can be referred for the adults and then as well as for the children. So next slide, please. This is actually an example of a community referral application. So this will give you an opportunity to look at some of the information that you need to provide. As we mentioned previously, Medicaid is a requirement to be a participant and to be eligible for the program. So when any individual can complete this, for an adult, it can be the individual themselves or a provider, or for children, of course, a parent can identify and complete this community referral. When we start talking about where to submit that, there's some variations between localities. So your local counties, have different ways, but I'm going to tell you all of the ways in which a referral can, and then if you have any questions as it pertains to your particular county, you can reach out to their single point of accessibility. This just provides some demographic information, some medications, as well as identifying what would be the eligibility criteria. Next slide, please. Here, again, starts to go through the different categories. And this is a look at the adult community referral, as it indicates serious mental illness. So you got the single qualifying as well as the two chronic conditions. You can take a moment and take a look at that. Next slide, please. So the referral mechanisms for children. Okay, there are basically 4 ways a child can come into a care management, to receive care management services from the referral. A community referral can be completed, and for targeted case managements, when they rolled over automatically into health homes. So the targeted case management, supportive case management, intensive case management, at the outset when we started in December of 2016, they all rolled over into health homes care management. You can also, as a care management agency, referrals are assigned through Medicaid Analytics Performance Portal, but they can be inputted in there by the managed care organizations, your local departments of social services, or your single point of accessibility, your county SPOAs, or their local governing units. All of them have access to submit referrals. So in your area, you can connect with your local county SPOAs, single point of accessibility, and send that information to them, and they can refer it. Also, if you have a relationship with a care management provider, in some counties you can go directly to them, or you can send it to the health home. Both can direct. It's really around parent choice, family choice, or individual choice to determine who they want to provide their care management services, as well as the health home in which they want to be a part of. So next slide, please. For the adults, it's slightly different. The care, any community referral that's completed is either sent to the single point of accessibility, or it's sent directly to the health homes, and then the health homes or the single point of accessibility will identify what health home and care management still based upon provider or the parent choice or individual choice if it's an adult. We also receive referrals from the Department of Health and Managed Care Organization of individuals that are high consumers of Medicaid, which we try to outreach to those individuals to offer them care management services. Next slide, please. Okay, we're going to have Phil go into and talk a little bit about what care management is and the work of the care manager.
Hello, everybody. Next slide, please. Okay, so the way we really look at what care management is we use this the idea that we are an air traffic controller, and the individuals we're working with are aircraft, and we have absolutely no control over which direction the aircraft goes. We might be able to see certain things, and we can guide them, and we can support them to get to their destination, but ultimately they have ultimate control over where they end up going. So that's a little bit of like how care management operates, is that we're working with the individual, trying to guide them and support them to first determine what that goal is, and then we work with them to achieve that goal by breaking it up into sizable, achievable objectives and helping take out some of the barriers that might be popping up that might be getting in their way of achieving these objectives. Next slide, please. So care management services are really broken up into the 6 different services. Really, when someone comes out to meet with an individual that is interested in health homes, these services are all provided by one individual, okay? But they're really highlighted as different services that we provide, different scopes of services that we provide, all by one care manager. So the first one is comprehensive care management. Comprehensive care management is really the idea that we're trying to engage with the individual. Really starts through that outreach stage where we're trying to meet with them, find out if this service is appropriate for them, to work with them to get supporting documents in many cases, and then to let them have an informed decision whether they want to join the program. Of course, the program is completely voluntary, and they can disenroll from the program at any time. Once they're enrolled, we work with the individual to complete a comprehensive assessment. For the children, we do the CAMS New York, the Child in Needs and Strength Assessment, and then we present the family with the findings of those results, and we work together to create a care plan. And with that care plan, we have a strong goal and objective that we're going to be working towards, and we work with them to break up into subset objectives, really in the eyes of or in the line of physical health, mental health, and social needs, to support them to get to their overall goal. So we just kind of break it up with them, and then we will work with them to have care meetings with their providers to make sure that everybody is on board with what the objectives and the goals are, and everybody is able to present how we're going to work together to support this individual achieving their goal. Care coordination, health promotion. That's a little bit like what Kevin talked about earlier when he had this slide around the silos of care. Is really to work with the providers, to work with the mental health provider, the chemical dependency provider, physical health provider, to make sure that everybody's on the same page. We have had situations where we've been working with somebody who was prescribing psychotropic medications. They didn't know, hadn't had a conversation with their physical health providers, and the physical health providers were prescribing medications for, health conditions. They didn't know they were getting psychotropic medications. So, that could cause some serious problems. And so opening up those doors of communication, making sure everybody's on the same page. And it really offers an opportunity for providers to be able to say, hey, you're working towards this. I can help you by doing X, Y, and Z. This is really in the scope of how I can support and help you towards whatever goal that the individual is working towards. Comprehensive transitional care from inpatient or from hospitalization. So this is really an important service that we provide. We actually get alerts from the hospital when one of our clients go to the hospital. And within 24 hours, we will go out and meet with the individual and try to provide transitional care. We're working with the discharge team there at the hospital with the client, so the client, is comforted, hopefully by us being there, and that we're all working together to have a successful discharge, to have a good, healthy plan for the individual to prevent rehospitalization. And a lot of times to help the hospital, care for the individual by filling in some of the blanks, some of the questions that it might have in regards to the individual's care or some of their needs. Then we have individual and family support. And this really is around the idea of working with the family and with the individual to understand, what's going on. How is this diagnosed, or what is this condition that's affecting me, and how best to support the individual, whether it's the family and how they can support the individual or the individual themselves, and identifying how these behaviors are maybe affecting their lives. So that's the individualized and family support. And we also, of course, provide referrals to community and social support services. So when we're working with somebody, we will work with them to identify what their needs are, and we will work to ensure that a referral is completed for every single need. So some may already be in place. So if somebody has, let's say, asthma, and that's one of their diagnoses, then they would probably have a primary care physician. If they had one already in place, we would go ahead and go right into the coordination of care. But if they don't, then we'll work with them to do a referral to a primary care physician. And so we do that across all areas, whether it's physical health, chemical dependency, mental health, or also social needs. And the last is really, it's not really a service that I think are at this point that the individuals we work with really will see, but it's really behind the scenes. And it's really the use of health information technology to be able to link the different services and be able to support the individual a little bit better by working with these computer systems. We're able to share information and reduce the chance of things being missed or people not knowing fully what's going on with the individual. And so it's still a work in progress, but every care management agency uses a health information technology system, and they're working to be able to connect and work with the different providers and with the individual themselves so they can be in charge of their own care and see their own care. Next slide, please. So that's a general overview of the Health Homes program. I think we have some questions.
We do have one, and I'm going to read it. And then, Nancy, you can let us know if we have more. Okay, so the question is, I understand that OPWDD will soon be adopting the health home model in order to deliver supports and services to adult individuals with developmental disability population. Can you speak to how this population can be effectively serviced by health homes for individual service plans, which don't necessarily need to incorporate medical and or psychiatric services? And it's really, there's still going to be two. I'm going to ask Kevin a sort of follow-up question. There are really still going to be two separate sets of health homes, right?
Yes, they are in the process of developing, using the health home care model. And this is how I understand it. I'm not an expert in the OPWDD system. But currently, individuals are not eligible for children's or adult health homes based on a developmental disability diagnosis. Right. If they are receiving OPWDD services and are connected. If an individual has multiple diagnoses at this time, they could still technically be eligible for both. Okay. But as they move forward, they're developing a care management model that's supposed to be very similar to the health home care management model for the OPWDD population.
know that we are, it is a constantly changing set of circumstances with that, but my understanding is that the plan is to start rolling that out in the middle of next year, and we will be having another learning community specific to OPWDD at that time. I'm pretty sure either Nancy or Barbara can confirm that we talked about maybe doing that in May when the information was a little more solid. If you can, let us know in the chat if that answered it. I mean, unfortunately, I think we can't answer it yet because they're not ready to roll out their public information quite yet. So we get a sort of answer.
Yeah, and again, I don't want to provide misinformation, right. But as you understand it, that is my understanding as well, that they're in the process of developing a health home model for the developmental disability population.
So there was another, I guess it was a statement more than a question, but I think it might be worth you trying to answer it. The concern is that health homes right now are don't feel like to participants like they're being managed very well, that there's not a lot of case oversight and not a lot of standardized training. So can you speak to the types of training, the types of support for caseload management that agencies are able to receive and to support the care managers?
Correct. I'll start, and then I'm going to also lead into Phil a little bit here. They've developed a champions model. So part of the champions model around health home, the health homes that we work with have developed a champions model. So it allows a person at the organization to provide training to those individuals that are receiving services with the support from the health home. Again, I can only speak from the health homes that we provide care management services for. And part of that is our required trainings for the children and for adults. Required trainings for some of the adults, I'll let Phil speak to. For the children, there's around cultural competency, around trauma-informed care, around mandated reporter, some of the other ones that I missed, parent engagement. So there's a variety of required trainings, and then they provide ongoing training as we go forward. In addition to, so there's a kind of a significant learning curve for many around using the health information technology. But then, as well as that, then they are trying to provide guidance as to around the conditions and challenges that the individuals that are receiving services, asthma, some of the medical conditions that the individuals are receiving. Phil, do you want to speak to some of the required ones for the adults?
Yes, and those are very similar for the adult system, HIV/AIDS. Getting very into some of the specific needs of the individuals that we're working with. The other thing I would like to point out just real quick is that, I absolutely agree. I think that as health homes came out, came out about 3.5, 4 years ago, and it's been a process. It was a very large endeavor by the state, and the state now is really going in, auditing, looking at health homes, looking at care management agencies, and really saying, folks, this is what we need to see. And one of the really great things about the health homes program is that we're really using the state's MAT system and Medicaid analytics and performance portal system, and able to capture data. So the idea is that your choice in which health home or which care management agency is going to be informed by how well they perform, to be honest with you. And it's going to really put a lot of pressure on care management agencies and on health homes to ensure that they're providing good quality services to the individual. So at this point, a lot of the so the question is, how big are the care management caseload sizes? And really, each care management agency is able to determine their caseload size by their agency. So it gets a little complicated. I won't go too far into it, but each individual that comes into the health homes either falls into one of two categories. They're either, for the adult health homes, it's going to be based off of whether they're in the health and recovery plan insurance plan and whether they're not. And if they are, that is one set of rates. And then the second one, which is not in that health and recovery plan insurance plan, they would have a different set of rates. So each agency will determine their caseload size basically off of the lowest possible caseload size they can do financially to keep their agencies running, to be honest with you. So we're constantly working with the state and trying to get caseload sizes down. But typically what you'll see is if some go and say, you know, this care manager is only working with high acuity, they can probably get it down to, you know, 15 to 20 maybe. But if the individual comes in as a low acuity and maybe it's non-HARP, they might be on a higher caseload, which could be anywhere. I mean, we are typically running at 40 person caseload sizes, but I've heard of some being as high as 100. And I know that a lot of those agencies were working hard to get those caseload sizes down.
Yeah, so speaking to the caseload size, there was guidance provided by the state as it pertained to the launch of the Children's Health Home. We try to stay as pretty close as we can to that model, but essentially for the higher acuity, you know, their recommendation was 12. We usually run, because again, some of our individuals have blended caseloads, more around 15 to 20 because they have some blended caseloads of high and medium. And then for the medium, it's really like 20 to 30, and for the low, it's really like 30. But because we have such blended caseloads, it's really at the care management discretion. What is required is that in the children's, you cannot have a care manager that's providing for the low acuity individuals also working with high acuity. And then for the adults, Bill mentioned the HARP or the Health and Recovery Plan. We do our best because these individuals, the requirements for working with these individuals are higher for staff requirements. So we also try to manage the caseload as best we can to be able to provide as comprehensive care management as we can.
So we have another question here. So once a person is connected to all the resources and services they need, can they unenroll in the program through the health home? And how hard or easy is it to get back into receiving them if they need that support again? That's a great question, and actually, it is very easy to leave the health home services, and it's very easy to get back in. So what we typically have done is we will work with somebody to identify what their goal is. Once they achieve that goal, we'll see if they have another goal. If they don't have another goal, then we'll say, hey, maybe this is the best time for us to go ahead and try to, discharge you, if you will, with a plan and how things are going to go. And then if anything comes up, they can call us back. And that has happened, and it works really well. One of our biggest successes was we had an individual, she was working with us for 4 months, I think, which is relatively a small, time frame. And we were able to connect her to a great housing resource. We were able to help her get into volunteering, which she really wanted to do. And we worked on some social things. And within 4 months, we agreed that, hey, everything she was looking for, she had achieved, and she was really happy, and she had a lot of resources. We had helped her get some, community resources and ensure that she had a primary care physician, et cetera. So she felt really good, and she went ahead and discharged. So yeah, it's really easy to discharge or to opt out or withdraw from the health homes program, and it's really easy to get back in. All they would have to do is another community referral.
So next question is pertaining to MAP. This question seems to mostly pertain to the outreach process for adults. MAP is not able to be shared with consumers, and often Medicaid numbers are solicited, and CMA care management agencies and health homes are billing for outreach, and the consumer does not even know that. At the outset of the adult health homes, part of one way in which care management agencies receive referrals is that the Department of Health or the managed care organization provides us information to outreach to individuals who are high consumers of Medicaid. And that information is provided. It does go through the MAP portal where it's really houses that's connected to the Medicaid data warehouse. But they provide that information and ask us to outreach those individuals. We're in the process of trying to revise the outreach model to really focus in on, getting the individuals engaged and connected to services. So they're supposed to be making a change to that model in October. There's some question on whether or not it'll be delayed. But really, your second question, this can happen for 3 months and then again over and over. This is some of the changes that they're proposing, and we anticipate in October or maybe delayed, is really around this, which is that you'll be able to outreach these individuals for 1 month. The second month, you can continue to outreach the individuals, but if you aren't able to connect with them face to face, it's really not a billable service. And then at the third month, you really would no longer, you would discontinue with those individuals, and they wouldn't be recycled like they have been in historically. Once there's it's what's called the hiatus period, and they're kind of eliminating the hiatus period. They are still very interested in engaging this high Medicaid recipient population to at least offer the service to them. But as Phil said, at any time, they can opt out. They can indicate they are not interested in care management services and therefore do not wish to proceed to enroll. And at any time, so even if an individual indicates that they want to participate, at any time they can decide to opt out at that point. We also, obviously, if we had been engaged with an individual and providing care management, but their circumstances change and they decide they want to opt out, they also have those relationships. So going back to the referral process, they can go right back to that care manager and say, hey, something happened, and can we try to proceed with getting back into health homes? And then the care management agency could help facilitate that. Or they may not have had a great experience with that care management agency or health home, and they can opt to choose a different one. And that goes back to some of the referral process that I explained previously. Can you talk a little bit about how a family who has a loved one with developmental disabilities and dual diagnosis can receive support through the mental health system specific to SPOA health home care management? Yes, there have been individuals that we have enrolled in health homes care management because they have those situations, and they're not, it's basically if they're not, they can be OPWDD eligible, they just cannot be receiving services. So if they have a Medicaid service coordination, then it would be considered a duplication of services. But if they're dual eligible, OPWDD and mental health, a family could choose to try to enter into health homes care management, and they would just want to communicate that to the local county SPOA and make sure, what we as a provider of it, what we just want to make certain is we're not doing any making any more challenges for the parent or the youth that's trying to access services. If we really think that we can be helpful for those individuals and they're eligible, we can enroll them as long as you're not receiving OPWDD services. What would happen to the plan of care if one opts out? Are you aware that the MCOs are required to provide person-centered care plan if the health home is not happening? Yeah, so we're trying to be, as part of our enrollment process, we want to, as far as our consent process, we want to include the managed care organization. We are regularly communicating with the managed care organization, certainly for the HART population where they're trying to access additional services, home and community-based services for adults, where that information goes back and forth. We do contact managed care organizations and share with them information pertaining to it, pertaining to the individual that we're providing services, and let them know if an individual has opted out and what were the identified goals and that we were working on while receiving services. It's really individualized basis because as providing care management, we work with a lot of different managed care organizations for the recipients.
Okay, so I think the questions have slowed down, so I thought I would just kind of give you guys a sort of softball summary question, which is that when you were going through all the list of criteria that people have, it's like they have to have this and they have to have that. On the one hand, it felt like really kind of restrictive, but on the other hand, if you look at those criteria and you only have to pick one in some cases, it really is pretty broad, and so you really are working for people to get people who are either chronically dealing with something or acutely. You're trying to get them in. So I guess speak to that just a little bit, this notion that it seems both restrictive, but really there are ways to get people in at the same time.
Absolutely. So I'll speak for the children and for the adults. For the children, it's within the last year, someone would have to have a certain diagnosis. And so, it does seem like quite a bit when we put it up on the screen like that. But and with the adult, with the adult, it is actually there is no specific timetable. With our One Health Home that we contract with, we go about 5 years back, and the other one, it's really a case-by-case scenario. So someone could be away from services for them a bit, and as long as we can get some supporting documentation that they had a mental health diagnosis of, let's say, depression, we would work with them. If their goal is to reconnect with a provider to get, support around that, we could go ahead and enroll them and then help connect them to a provider to help them, with their depression. So, but when you're looking at the different qualifying conditions, so if somebody has schizophrenia, they would qualify just because they have schizophrenia, okay? And if they had, they would have to have a need for the program, okay, a functional need. And so if they have schizophrenia, and let's say that they do not have adequate housing, let's say they're living in a dangerous area and they're at risk of, danger or something along that line, that would actually qualify them. Plus, they would have to have Medicaid. But that would qualify them for the program. So, and when we go for two qualifying conditions, you're talking about somebody could have anxiety and asthma and qualify for the program. So, it would definitely have to be two things that they're going to be working on, okay, and they need some support around, but it would be two qualifying conditions. And really the idea is they really set the bar, I feel, can sometimes really low in a sense, but you're not going to be able to do a whole lot of sustained care if the needs aren't really there. And there's no point to provide services if there really is a need. But if the need is there, the diagnosis piece is really just a, kind of a roadmap, if you will, and where we're going with things.
Yeah, I'll just add to that. The providers oftentimes, when you're working with an individual, and that's one of the purposes, the design around the outreach. If you have an individual, but they may be disconnected or just haven't, been to their primary care, or haven't been to their mental health provider, we can utilize the outreach period to really get them connected so that we can then gain the eligibility, the criteria that would make them eligible. Phil spoke a little bit to. We're also aware that there are individuals that are able to manage their care on their own, so that really speaks to the appropriateness criteria. It's really, do they need care management services really to manage the challenges that they have? We have found that we get a lot of individuals in, even if the initial referral shows that they've not connected and disconnected to the services, we've been able to work with them and really collaborate, especially if we identify that there's a real need there. We want to work to best support them, so it may just be a process in which to get them eligible and enrolled.
All right. Well, I am going to wrap up for the day. I want to remind you that if you are not on our newsletter or want to hear more about the mini grants, our website is www.nystransitionpartners.org, and you can there's a button there to subscribe to the newsletter, and under opportunities you can find out about the mini grants. And that is all. Thank you very much to Phil and Kevin and Lynn, and we are going to wrap up.
Thank you, everyone.